If you have been taking amlodipine for years and your clinic reading looks fine, your morning blood pressure may still be dangerously high, and your doctor has probably never checked it. Not sometimes, not occasionally. Every single morning during the 6 to 10 a.m. window, your blood pressure climbs to its highest point of the entire day, and your doctor has probably never seen that number. The reading they rely on, taken at 11 a.m. or 2 p.m. in a clinic chair, is almost always taken after that window has passed. Your ankles may be swelling. Your resting heart rate may have crept up since you started the medication. You may have been told these are just aging, or told to take a water pill. There is a specific reason none of those explanations are complete. By the end of this video, you will know the 3 questions to bring to your next appointment. Most people on amlodipine have never been given them. Beverly checked her monitor every morning. Same reading. She had been told it was perfect, but the reading she was checking and the reading that mattered most were not the same reading. I'm Dr. Sarah Kim, emergency medicine physician, 15 years in preventive care. Let me show you what I found. In emergency medicine, I see what happens when the readings that get tracked are not the readings that matter. One of the most consistent gaps I see in my practice: how amlodipine is monitored in patients over 70 over the long term. Have you been on amlodipine for more than a year? And have you noticed any of these 3 signals: swelling, morning readings higher than your clinic reading, or a gradual heart rate increase? Leave it in the comments. I read everyone. Here is what amlodipine actually does inside your arteries and where it stops. Think of your arterial walls like a door with 2 different lock cylinders. Most blood pressure medications that work through calcium channels, including amlodipine, are cut to fit only one of those locks. That lock controls how much the artery wall tightens. When amlodipine fits into that lock, it relaxes the arterial muscle wall, the pressure drops, and your midday reading at the clinic looks fine. But there is a second lock. This one sits on your nervous system, the system that controls how your body responds to stress. Amlodipine does not reach that lock at all. This matters enormously after 70 because your body's stress response system, the sympathetic nervous system, becomes more reactive with age, not less. And there are 3 specific ways that second lock being unaddressed shows up in your body. The first is your morning blood pressure surge. Imagine a tide. Every morning, between 6 and 10 a.m., your stress response system releases a stress hormone called norepinephrine. Like a tide coming in, blood pressure rises with it. In healthy adults, that tide is modest. In people with high blood pressure over 70, that morning surge can push the top number 30 to 40 points above the afternoon reading. Because amlodipine never reaches that second lock, it cannot stop that morning hormone surge. The tide comes in regardless. Your clinic appointment is scheduled at 11 a.m. or 1 p.m. By then, the tide has gone back out. The reading looks fine. The surge is invisible. This is a measurable, documentable gap in monitoring, not a theoretical one. The second mechanism is your ankle swelling, and why a diuretic will not fix it. Picture a garden hose with the nozzle partially open. Amlodipine relaxes the large arteries, the main hose, so blood flows more easily. But the body's stress response system detects that pressure drop and fires a compensatory signal: constrict the veins. The return side of the circulation tightens while the delivery side stays open. Fluid gets pushed out into the surrounding tissue, in the ankle, because gravity pulls it there. This is not water retention. A diuretic removes excess water from the bloodstream. It does not touch the stress response reflex that is pushing fluid into tissue in the first place. If you were prescribed a diuretic for amlodipine ankle swelling and it did not work, that is exactly why. That is a specific question to bring back to your prescriber. The third mechanism is your resting heart rate. The same nervous system signal that tightens your veins also pushes your heart rate up. Not dramatically. 2, 3, 4 beats per minute. Gradual enough that it looks like aging or anxiety or something vague. If your resting pulse has climbed since you started amlodipine, that is worth tracking and worth naming specifically at your next appointment. All three of these, the morning surge, the ankle swelling that does not respond to diuretics, the heart rate rise, are the same root mechanism, your body's stress response system compensating for what amlodipine's one-lock-only design cannot address. Here is what the research confirms. When a blood pressure medication reaches both locks, not just the one amlodipine reaches, three things happen. Morning blood pressure comes down in the window your clinic never sees. The nervous system signal pushing fluid into your ankles weakens. The heart does less extra work. These findings have been replicated across multiple studies, in patients over 70 specifically. The older the patient, the larger the gap between the two approaches. Beverly's cardiologist was looking at none of this. The clinic reading said fine. The morning window was invisible. None of this research argues that amlodipine is the wrong medication for you. It is widely prescribed, it is effective, and it has decades of safety data. What the research documents is a specific set of problems that amlodipine was not designed to address. Problems that get more pronounced after 70 and show up as trackable signals in your own home monitoring. Here are the three specific questions to bring to your next appointment. The first question is about your morning reading, the exact words to use. My current monitoring only captures afternoon or clinic readings. I would like to add a morning home reading, taken between 6 and 8 a.m., before I have taken my medication. Can you help me establish that protocol and tell me what number would prompt a change? This is not asking your doctor to do something unusual. It is asking your doctor to look at the window they have never seen. Many cardiologists will respond immediately to this framing. The second question is about your ankle swelling, but only if you were given a diuretic for it. The exact words: I was prescribed a diuretic for ankle swelling that started after I began amlodipine. The swelling has not resolved. I have read that amlodipine swelling may be a sympathetic reflex rather than fluid retention. Is that mechanism relevant to my case, and should we be looking at a different approach? You are not telling your doctor what to prescribe. You are naming the mechanism gap clearly enough that your doctor can respond to it specifically. The third question is about your resting heart rate. Before your appointment, track your resting pulse every morning for 1 week. Take it before you get out of bed, before caffeine, when you take your blood pressure reading. Bring those numbers, the exact words. My resting heart rate has changed since I started amlodipine. I have been tracking it alongside my morning blood pressure for the past week. I want to make sure we are looking at the full picture, not just the clinic reading. These three questions are not complaints. They are data. Doctors respond to data. Bring three measurements: your morning reading, confirmation that a diuretic did not resolve the swelling, and a week of resting pulse readings. Give your prescriber something concrete to act on. One more thing worth knowing. This research comes largely from Japan and South Korea. There, a different type of blood pressure medication, one that reaches both locks, not just one, has been used in older patients for over a decade. That drug class is not currently approved in North America or the United Kingdom. What the research documents is that these side effects and monitoring gaps are not inevitable. They are mechanism-specific. And that conversation with your prescriber is supported by documented research. Beverly sat at her kitchen table every morning, checking her blood pressure monitor. The same 124 over 78 she had been told was perfect. Her ankles had been swelling into her shoes since the second year on the medication. Her cardiologist added a morning reading and adjusted her medication timing. 6 weeks later, the sock marks that were still there by noon had moved to late afternoon. The 6 a.m. reading that had been running at 158 came down to 131. Her resting heart rate, which had crept up 4 beats per minute since starting amlodipine 3 years earlier, came back down by 2. She told me the number on the monitor had never been the problem. The problem was which reading she had been checking. I want to be precise about what changed and what did not. The ankle swelling did not disappear. It shifted. The morning reading came down significantly, but it did not reach the same level as her afternoon reading. 6 weeks is not the full picture. Her cardiologist will continue monitoring over the next several months before drawing any final conclusions. But the 6 a.m. reading that had been invisible for 3 years is now on record. That is the change that matters most. You came into this video knowing your clinic reading looked fine and something still felt off. You are leaving it as someone who now knows the 3 questions to bring to your next cardiology appointment. Drug-induced ankle swelling and morning blood pressure surges are very often addressable when the right mechanism is identified and the right monitoring is in place. The goal is not alarm. It is a more complete picture. If someone you love has been on Amlodipine for years and still has swollen ankles, share this with them before their next appointment. And if this is the kind of information you want to keep receiving, specific, sourced, accurate, subscribe. Every video I make is built on the same standard. Imagine standing up tomorrow morning and checking your monitor before your medication. For the first time, seeing the number that has been running in the background. That reading is available to you. You just have to know to ask for it. This is general health information. Nothing in this video is medical advice. For your own case, have an informed conversation with your own physician who knows your full history.